A weightlifter comes to your office with complaints of inability to pinch since last 6 months. He had an interscalene block for a shoulder surgery and complaints of pain in the forearm, but no other problems. The patient is a weightlifter and reports no specific episode of any trauma. When you examine the patient, the evident finding is that active flexion of the distal interphalangeal joint is not possible. There is inability to flex interphalangeal joint of the thumb and the distal joint of the index finger. Weakness of flexor pollicis longus and flexor digitorum profundus. Moreover, when you continue to examine, you find that at flexion of the elbow, the pronation is weak. Further examination reveals there is a positive tunnel sign over proximal forearm, radiating distally. Requery confirms that he does have proximal volar forearm pain, but no atrophy or sensory changes. What is it? The differential here can be isolated rupture of flexor pollicis longus, rupture of flexor digitorum profundus, laceration of a nerve, tumor of the forearm, or anterior interosseous nerve palsy. Indeed, in this situation, EMG confirmed the diagnosis of interosseous nerve syndrome. Nerve conduction tests are often normal. X-ray should be taken to ensure there is no underlying cause or fracture. While talking about anterior interosseous nerve palsy, it was first described in 1950s, seen sporadically in athletes, resulting from violent muscle contraction or aggressive forearm exercises. Trauma or a structural anomaly can cause anterior interosseous nerve syndrome. Isolated anterior interosseous nerve syndrome may also be seen in acute brachial neuritis caused by sports or post-anesthesia from an interscalene block. Anatomically, it is caused by the compression of interosseous branch of the median nerve by a fibrous band from the deep head of pleural teres or flexor digitorum superficialis. Anomalies in the vessel or muscle can cause it. Flexor carpi brevis or palmaris profundus. Its origin is usually 5 cm below the level of medial epicondyle. It travels through the forearm distally with the median nerve. It gives off a motor branch to the flexor pollicis longus. The anterior interosseous nerve exclusively innervates the flexor digitorum profundus of the index, whereas the flexor digitorum profundus of the middle finger is innervated by interosseous nerve in only 50% of the time, which can escape the paralysis. The syndrome is invariably reported in athletes such as pitchers, tennis players, gymnasts, weightlifters, and football players. Diving deep to the treatment of anterior interosseous nerve palsy usually is based on the specific etiology. Conservative treatment include ice, rest, and NSAIDs, and this should be continued for 8 to 12 weeks before discussing surgery. Some will advise to continue non-surgical management for more than 6 months. A post-anesthetic acute brachial neuritis of the anterior interosseous nerve should be given at least 4 months of conservative treatment before a surgery should be considered. There have been improvement for up till 18 months. But often it is reported that the return is often unpredictable and a total recovery is sometimes not expected. Regarding surgical decompression offers a more rapid recovery in most cases, If there is no clinical or EMG improvement in the 8 lumen, 12-week period after injury, surgical exploration can be undertaken. The surgical exploration normally consists of identifying the median nerve from the proximal forearm and following the anterior interosseous nerve distally, identifying all its branches on its way. The incision starts 5 cm above the medial epicondyle, extends distally over the flexor mass. The median nerve is identified proximally medial to the brachial artery. Its course is followed distally to the superficial head of poroidal arteries. The poroidal arteries is mobilized and separated from the flexor carpi radialis, allowing exposure of the nerve. The nerve is exposed where it emerges from beneath the flexor digitorum sublimis. The nerve is traced proximally by retracting flexor carpi radialis laterally and pronator proximally, and by separating the fibrin of FDS. The anterior interosseous nerve emerges from the posterior medial side of the nerve after passing through the two heads of poroidal arteries and supplies the flexor pollicis longus and the radial half of the flexor profundus and the poroidal quadratus. In most cases, the median and the anterior interosseous nerve passes through the superficial and deep head of poroidal arteries. Post-decompression of bulky dressing is applied and long-arm splint is applied, keeping the elbow in 9 degrees of flexion and the forearm in 45 degrees of pronation. Immobilization is continued for 14 days. Then, at change of dressing and removal of suture is done. Immobilization should be continued with the custom slits for an additional 4 weeks, and light range motion started under the supervision of hand therapist. Weightlifting should not be resumed at least for 6 months post-operatively.